Hello, everybody. Welcome back from the breakout sessions. I hope that you had interesting, inspiring, and fruitful conversations. I know from the little pieces of the breakouts that I've seen so far, I'm inspired. I'm really looking forward to watching the recordings. By the way, we recorded all of the breakouts. We will make those recordings available to all of you. So you're able to go back and watch the ones that you were not a part of. So we're going to get the second session of the day started with one more success story video. So let's watch. That's just great. I love those stories. Next, I get to introduce one of the coolest people I know, Rachel Atchison. Anybody who knows her probably agrees with me that she is the coolest. Rachel has been working with our mayor, Eric Adams, for the last 4 years and currently serves as a senior assistant to the mayor, as well as serving as the animal welfare liaison, which is the only position like this in the country. Rachel started off as the deputy strategist for then Brooklyn Borough President Adams, where she worked on plant-based nutrition initiatives, including launching Bellevue Hospital's plant-based lifestyle medicine program, which we just heard about in one of the panel presentations. She's also really done a lot to expand the resources available to Brooklyn residents who might benefit from access to information around plant-based nutrition. We are very proud to have her as the at-large director of SUNY Downstate's Committee on Plant-Based Health and Nutrition. Everyone, please welcome Rachel Atchison.
Okay, so when Columbus was speaking about stress earlier, I now do not give a lot of talks anymore. I used to actually travel around the country giving talks on animal protection, and now I'm surrounded by so many badass people in the field that give talks about these topics that it is a true honor to stand amongst the giants in this space. So as an honorary member of the Mayor's Office of Food Policy, I'm going to share a little bit about the Plant Forward initiatives that New York City has been embracing. So before I do that, I wanted to take a minute to say that this conference and the SUNY Downstate Committee on Plant-Based Nutrition have really been there since the beginning. We have partnered in many ways over the past several years to where now SUNY Downstate, to me, is a beacon of what New York City has to offer in this space. The fact that we have a plant-based nutrition conference for Brooklyn, for New York City, is amazing. When you think about the large conferences happen in DC, they happen in Los Angeles, but no, we have begun to make our mark here. And the mayor, then the Brooklyn Borough president, was not new to this. He has been true to this for a while, and he's been doing things like advocating for Meatless Mondays in the hospital system. So on the photo on the left is him at Coney Island launching that Meatless Monday program almost three and a half years ago. He hosted events at Brooklyn Borough Hall with Dr. Neil Barnard from the Physicians Committee for Responsible Medicine. We brought people, CEOs of hospitals, chief medical officers to Brooklyn Borough Hall. We really started to have this conversation in a real way. We devoted a lot of time and energy to getting the message out. One Brooklyn was our community newspaper. We dedicated a lot of time, in essence, airwaves to the message. We even traveled to DC to testify in front of the National Dietary Guidelines Advisory Committee on the 2020 guidelines. So simultaneously, in the mayor's office under the de Blasio administration, the mayor's office of food policy under that administration launched Food Forward NYC. And a little over 100 days ago, but who is counting, we were able to join forces, and the mayor's office of food policy and Eric Adams are now one. And they're really kind of pushing forward the vision that under the de Blasio administration, the people in the Mayor's Office of Food Policy had really all along. And so I'm very excited to be talking about what food policy in New York means. I was just at a conference a few days ago in Los Angeles, and folks were asking me, oh, what do you mean when you say food policy and government? And sometimes because food is not a political topic of conversation, people are confused by that, when they really shouldn't be when we look at how many meals. I mean, we're serving roughly 230 million meals to New Yorkers every year. And that means it's happening in our school system, it's happening in our jails, it's happening in our hospitals, it's happening in our senior centers. And the reach of what we determine to serve is truly incredibly far-reaching. So as we look at what role food policy plays in the administration, we have to get the right leaders in place. And so you've already begun to see our commitment to nutrition and to lifestyle medicine take place. Absolutely, I see the Plantastics team is here. We put Michelle McMacken as the head of nutrition and lifestyle medicine in H&H, and H&H has just done a tremendous job in this space, and I'll be speaking a little bit about that further down the line. We've begun to look at where our food policies can be made a little bit more plant forward than maybe they explicitly had been previously. So we issued 2 executive actions back in February. Executive Order 8 is the commitment to food nutrition. It talks about the good food purchasing policy. So looking at a value statement of where is our food coming from? What sort of sustainability indicators are we looking at? What nutritional profiles are we looking at? What animal welfare are we looking at? And then Executive Order 9 is looking at what are the foods that we're promoting on city property and wanting to really prioritize promoting healthy food. And we're doing something that is not necessarily the most sexy work, but it is truly monumental work, and that's done by our Department of Health, issuing food standards that right now we're issuing them every 3 years at least, and that's issuing the best nutritional data that we possibly can muster. And so we are very proud of those food standards and excited that as time continues, they are becoming more and more plant forward. But we're not waiting for the randomized control trials that some might want in this space to say, hey, let's eat more plants. What does an eating more plants administration look like? It means serving delicious plant-based food at our events. So any events that we're hosting, we're serving amazing food that, guess what, people are loving. It is phenomenal to go to. This was last week at our iftar dinner. It's phenomenal to go to. Last night we had our Cinco de Mayo celebration and see and taste this amazing cuisine and try and get over the hurdles of what people envision plant-based eating to be and instead just serve them delicious food. It's been fantastic. And of course we launched Plant-Powered Fridays in our school system. We're focused on bringing back the salad bars to each school after COVID really shut that system down. And the city's social media reaffirms that commitment. And if you do not follow New York City, the mayor, on social media, I highly recommend you do, because sometimes I just have to pinch myself with how amazing our team is for bringing this message and spreading this message far and wide. Everything from filming tutorials on how to make the mayor's morning smoothie to working alongside colleagues who host events like with our Mayor's Office of Immigrant Affairs, where we hosted an event making more smoothies out in the community at Lincoln Hospital. Even the HR newsletter now features things like recipes from Tabitha Brown. And our health and hospitals team, I just want to pause and take a second because this agency has jumped more on board with lifestyle medicine than even my wildest hopes and visions. And when we launched the Bellevue Clinic almost 4 years ago, it was a pilot. It was a $400,000 investment into the space, and we would look at the data. We'd look at to see whether we could expand this. And I'm so proud that back in February, we expanded that program from 1 hospital to 7. So we have just begun that staffing up process and really bringing plant-based lifestyle medicine programming to each borough. So it is truly, again, one of those pinching moments. And then when you see Bill Clinton applaud the work on social media, there's a double pinch right there. We'll continue hosting events that never before looked at food policy and now have a lens of food policy. When the mayor, when folks at the mayor's office brought, hey, what do you want to do for your Black History Month event? He immediately said, well, of course, we've got to focus it on food. So we've got that in the pipeline. And we also, I think Columbus said it wonderfully earlier, if kids grow the food, they're going to eat the food. And we are expanding urban agriculture like none other as well. We're launching an office of urban agriculture within the mayor's office, and we'll be seeing some fruits of that labor in the next couple of months. We'll continue to look to ways to honor those who serve us food, because this is an ecosystem. It is not a monolith. It is so many different feeders of how our system is run today. And honoring those who serve us food, like these District 37 laborers, was truly a special day in City Hall. And we're going to have an even amazing opportunity coming up, because the White House is hosting a White House conference on food, nutrition, and hunger, and we will be playing our part, so more news on that to come. We'll continue talking to anyone and everyone about the mayor's morning smoothies. And because after all, it's built into the mayor's fabric that he is indeed the broccoli mayor. And with that, I will conclude and give the time to Michelle. Thanks so much.
Thank you, Rachel, for everything that you're doing with the mayor's office. Spectacular. So to wrap up today's talks, we're about to hear from some unique clinical intervention programs. They're happening right here in New York City. These programs are led by two of the real superstars of lifestyle medicine in New York. Some of you got an opportunity to hear from Dr. Oswald in the last breakout session, but we'll be hearing from Dr. Michelle McMacken and Dr. Rob Oswald. We'll first hear from Dr. McMacken. I'm going to introduce both of them now. We'll let Dr. McMacken go, and then we'll have Dr. Oswald go, and then at the end, we'll have some time available for questions and answers from the audience. So Dr. McMacken is the Executive Director of Nutrition and Lifestyle Medicine at New York City Health and Hospitals, the largest public healthcare system in the United States. Dr. McMacken previously directed Bellevue's adult weight management program from 2005 to 2022. And in 2019, she developed and launched the innovative Bellevue plant-based lifestyle medicine program. It's so amazing to have so many of the amazing clinicians here with us today from that program. Dr. McMacken is also an associate professor of medicine at NYU Grossman College of Medicine, and she'll be telling us about the expansion of lifestyle medicine programming in New York City. And Dr. Oswald is the director of preventive cardiology and the founder and director of the cardiac wellness program at Montefiore Health System. His research focuses on cardiovascular disease prevention through lifestyle modification, and he speaks widely on this topic. Both Dr. McMacken and Dr. Oswald are beloved and award-winning teachers, which I'm sure you probably already have gathered based on talking to them today. It's really a delight to have both of them here, and let's get started with Dr. McMacken.
Good afternoon, everybody. How's everybody doing? It's a great conference. I'm so honored to be here, and thank you so much for that kind introduction and the invitation, Dr. Helsner. So I will be speaking today on our experience at New York City Health and Hospitals in the plant-based lifestyle medicine space. Start by letting you know I have no financial disclosures, but because I will be discussing food, I am forced to let you know that I'm all about my veggies. Today I'm hoping that through this conversation you'll come to understand a little bit more about the mission, the structure, and the outcomes at our Bellevue plant-based program that together sort of discuss some of the benefits of using a plant-based lifestyle medicine approach for not just preventing but actually treating cardiometabolic disease, and I'm sure you've already heard some of that today. And finally, we'll explore some of the goals and challenges in expanding lifestyle medicine throughout traditional health systems. So I want to take you back to September 2017, the steps of City Hall. I'm sure you recognize at least a couple of people here. And this is where an idea took root. And this idea was really inspired by the health journey of none other than Eric Adams, then Brooklyn Borough President, and now the Mayor of New York City. As most of you know, he had been diagnosed with type 2 diabetes, very elevated blood sugar. He also had many symptoms. And he was told there's not much you can do other than take insulin and some pills. So he did some research on his own, and he learned about a plant-based lifestyle. He started enacting that lifestyle, and here today, Mayor Adams has put his type 2 diabetes into remission, which I can tell you is one of the most remarkable things that I've seen as a physician. When I've seen this in my patients, it's one of the best feelings you can ever have, not to mention how good it must feel for the patient. So the idea was, let's give all New Yorkers that support that they need to get healthy using a plant-based lifestyle medicine approach. Let's get medical teams that know about this, that can help support our patients in doing this so that they don't have to necessarily just go out and do their own research and not have any support. So what exactly is this term, lifestyle medicine? What does that mean? Well, it's really an evidence-based approach to preventing, treating, and in some cases even reversing lifestyle-related conditions through the adoption of healthy behaviors. And we can think about it in these 6 different pillars. So there's healthy eating, there's physical activity, there's stress management, which we heard a lot about today from Dr. Batiste, and I would fold resilience into that. There's forming positive relationships and social connections. There's improving sleep. How many people here have thought about, I should probably sleep a little bit more? Right? And we've seen that too in our patients in the Bellevue program. Sometimes we want to talk about plants and plants and plants, but we realize the person's not sleeping. And sometimes that's way upstream, and that's one of the first lifestyle pillars that we address. And it's of course about avoiding risky substances like tobacco. Now, of all these pillars, when you look at the science around lifestyle medicine, probably what we eat has the biggest impact. It's probably the most important because we know that a suboptimal diet is actually the #1 risk factor for dying of a chronic disease. Not just in the United States, but actually globally. But it's very powerful when you put numerous lifestyle habits together. So I think this is probably one of the best titles for a study that I've ever seen. And this is a very large prospective cohort study in which the researchers identified these 4 factors, which were never smoking, exercising 3.5 hours a week, eating a healthy diet, and having a body mass index less than 30. So the first 3 are directly lifestyle habits. And what they found is that the combination of all 4 of these factors was linked to a 78% lower risk of having any one of these outcomes. Type 2 diabetes, myocardial infarction, which means heart attack, stroke, and cancer. 78% lower risk. That's amazing. So this is just to show sort of the power of when we put all of these healthy pillars together, what kinds of benefits we can have. And what about if it runs in your family? What if you have a high genetic risk? Oh, heart disease has been in my family as far back as I know, or cancer's in my family as far back as I know, or like so many of my patients who come to me and say, my mom has diabetes, my dad has diabetes, my brother has diabetes, obviously I'm gonna get diabetes. And the truth is that lifestyle can still play an enormous role. This is a study looking at individuals at high genetic risk for coronary heart disease. And what they found is that among participants that were at a high risk, a favorable lifestyle was linked to a 50% lower risk of coronary artery disease compared to an unfavorable lifestyle. So there's so much we can do with the lifestyle habits that we have. And this is why major medical societies all emphasize the role of lifestyle as really the foundation. So whether that's for diabetes prevention or treatment, whether that's for cardiovascular risk reduction, or whether that's for cancer prevention and survivorship, they all unify around a healthy lifestyle. So why plant-based? In case you just walked into this conference right now. And what is a plant-based diet? In case you really are just walking in now. Well, a plant-based diet is essentially a diet that's very rich in all kinds of fruits and vegetables, as well as proteins from plant sources like legumes, healthy plant fats such as nuts, seeds, avocados, and of course whole grains, my personal favorite, oats, brown rice, quinoa. And it's really putting all of these foods on the plate. It doesn't have to necessarily be 100%, but we know the farther that people go on this spectrum of moving towards a plant-based diet, the better. If I have a patient that comes into my office and is starting out 20% plant-based and they move to 60, that's a huge win. And we're, of course, there to support them to go as far as they want and can. So what are the benefits that you can see? Well, these are just some of the scientific, summary of the scientific literature. So across the board, very consistently, interestingly, in the epidemiologic research, you can see about a 25% reduction in the risk of coronary heart disease with a plant-based diet. You can see improvements in blood pressure. You can see significant reductions in your LDL cholesterol, huge decrease in the risk of type 2 diabetes, of course, improved blood sugar control if you already have diabetes, and in some cases, even remission, just like we know with our mayor, decreased incidence and progression of chronic kidney disease, as Dr. Joshi can attest, healthy weight management, and a lower cancer risk. I mean, come on. Lots to love. So how did we take this idea and put it into practice? So together with Mayor Adams, then Brooklyn Borough President, the Mayor's Office, and New York City Health and Hospitals, we were able to launch the Bellevue Plant-Based Lifestyle Medicine Program in 2019. And our mission there was to provide intensive support for these evidence-based lifestyle changes. We really also wanted to reach communities that were at a disproportionate burden of cardiometabolic disease. Communities that are facing the highest burden of hypertension, of type 2 diabetes, and who were also at the same time facing the biggest barriers structurally to actually making lifestyle changes in the first place, the folks who really could benefit the most from our support. And I'm very proud to say that our program was the first of its kind in any public healthcare system in the country. Now, Bellevue has had a lot of firsts. It was actually the first hospital in the United States that's still running. It had the first maternity ward, it had the first ambulance, it had the first combined children's school and TB sanatorium. We cured and treated Ebola. So we figured, if we can do all these things, like curing Ebola, we could probably help people eat more broccoli. All right, so let me tell you a little bit about the context at Bellevue. Of course, again, this is a public hospital that serves all New Yorkers, regardless of their ability to pay. About 68% of our patients either have Medicaid or have no insurance at all. We have a very large immigrant population. It's very ethnically diverse, and a significant proportion of our visits are conducted in languages other than English. So as my team can attest, especially in primary care, in a given week, you will use an interpreter to speak any number of these languages, and then some. So for our program, we selected really the cardiometabolic conditions as our eligibility criteria. So adults that have type 2 diabetes, prediabetes, hypertension, atherosclerotic cardiovascular disease, or health concerns related to obesity. And we got referrals in two different ways. The first is through internal e-consult referrals. That means providers within the health and hospital system can actually refer patients directly to us. That launched last year. And from the beginning, we've had this capacity to have individuals in the community self-refer. And that was really important to us because we knew that maybe not all physicians or other practitioners out there would be familiar with plant-based lifestyle medicine or even lifestyle medicine in general. So we wanted to put the power in individuals' hands to be able to seek the support that they needed. And boy, did they seek it. So this is our contact center team dedicated number that we had to develop because we had so many calls. We said we need our own hotline. We need a broccoli hotline. So this is our interdisciplinary team sitting conveniently right here in a row. We're just missing one of them. So that's really our secret sauce. So we have 4 physicians, and they're working part-time at 0.1 FTE each. We have a full-time registered dietitian, Lily Correa. We have a certified health coach, Chris-Ann Polito-Muller. We have an exercise trainer who's not here today, our program coordinator, who's also not here, our fabulous, fabulous volunteer, John Babich. And of course, I include the PCP here. Sometimes we're the PCP, the primary care physician, for the patients we see in our program, but in most cases, our patients have an outside PCP. And it's really great for us to collaborate. We sort of see ourselves as physicians as co-managing our patients' chronic conditions along with their PCP. We just focus on the lifestyle part. So if I'm seeing a patient that has type 2 diabetes, like I saw the other day, and she's on a medication that rapidly lowers blood sugar, a type of sulfonylurea, and her A1C is coming down, her sugars are going way down, I will decrease her medication or stop it, and I'll call her PCP and say, hey, your patient's doing so well, we're able to decrease this medication. I just wanted to let you know it's for her safety. Similarly, I had a patient last month who came to me super motivated to change his diet. And I looked over his medication list, and he's taking an anticoagulant called warfarin. where you don't have to limit, but you have to be very consistent about your intake of vitamin K-rich vegetables and foods. So as we were telling him, we really want to have you eat more vegetables, more leafy greens, he was like, oh, I can't do that. And I said, well, it's true, it's a little trickier. Let me talk to your PCP. And I spoke to his PCP. He had non-valvular atrial fibrillation, and he was actually a candidate for being on an alternative medication called a DOAC that does not have any interaction with food. And so now he's eating all the vegetables that he wants without any concern for his blood levels of his anticoagulation. So this is just an example of our collaboration. Our patients flow through the program. We have an active phase and a support phase. So in the active phase, our patients have 2 to 3 visits with each clinical member. So with the physician, with our dietitian, and the health coach. And then they have 22 weekly group sessions through video, 14 of which are what we call our Lifestyle Starter Series, which is led by Lillian Kersan, our dietitian and health coach, that goes through the pillars, education around the different pillars of lifestyle medicine, and then 8 exercise classes. We have the ability to give out resources to our patients, including plant-based cookbooks, resistance bands for exercise training, and our starter guide to a plant-based diet that we developed. We have an amazing private Facebook page. And this is where folks, patients in our program who decide to sign up for the Facebook group actually can post their meal prep, they post their recipes, they give each other support. We have recordings of our group session without patients present, of course, for HIPAA. For individuals who want to go back and watch the recordings, it's just a wonderful space. And we have a lot of check-ins through MyChart. And then in the support phase, we have a monthly video group support. That's both in English and Spanish. We still have that Facebook page, and we have individual visits as needed. So these are just the topics that are included in our Lifestyle Starter Series. So you can see that they cover the gamut from the introduction to the plant-powered plate, label reading, recipe makeovers, fitness fundamentals, mindful eating, stress management, sleep health. It's really very comprehensive. This is Lillian Kersan at one of our live cooking demos before the pandemic, where they made tempeh tacos. It was a huge success, and actually, not only were the patients really excited about it, but we had a lot of staff at Bellevue walking by and kind of coming in and sitting in on the cooking demo, so that was really fun. And this is a screenshot of our starter guide to a plant-based diet that we developed, which is also available in Spanish. This is a picture of one of the sort of nutritional foundations of our program, which has to do with what we call the plant-powered plate. And what we like to do when we speak to patients about transitioning to a plant-based diet is not just to increase and sort of crowd out, use plant foods to crowd out other things on the plate, but also achieve balance on the plate between different types of plant foods. So it's kind of a reworking of the traditional My Plate model, but in a plant-based form. So where you can see here that half of the plate is filled with those non-starchy vegetables, emphasizing whichever ones the patient happens to like. A quarter of the plate can be a starchy vegetable or a whole grain, and a quarter of the plate is usually a plant source of protein like lentils or beans or tofu. And then, of course, you can add your whole food fat sources as dressings or condiments. Our approach to lifestyle change with our patients, I think first and foremost, we all recognize that we want to understand why is the patient in our program. What do they ultimately want to achieve? What's their vision? Is it that they want to get healthier so that they can feel better and have more energy? Is it to be there for their grandkids' high school graduation? What is it that is really making them click to want to make these changes? So we can use that as an anchor throughout their process in the program. We do a lot of very patient-centered action planning. So that really looks like talking to someone about, not me telling you, I want you to go home and eat more broccoli. That's not how it works. It's more like, tell me about your life. Tell me about what foods you like. And how can you start incorporating these more in your diet? How can you set a very specific plan? And I'll help you adjust that. We, of course, tailor to everyone's cultural background, to their family situation, to their socioeconomic status. We pay a lot of attention to our patients' social needs, which can affect their ability to make these changes. And as I alluded to before, we are huge cheerleaders. I mean, we will literally celebrate any movement towards a healthier lifestyle so that people come in and they feel good. I mean, it's hard. It's hard to change your lifestyle. So why not celebrate the small changes so people can feel more excited and more empowered to keep going? Now the boring stuff, billing. So physician visits in our program occur within our primary care center, so they're billed as if they were any other primary care visit. That's not been an issue. Dietitian visits are covered by some insurances in certain conditions, but otherwise the insurance coverage we've found has definitely tended to be variable. Our health coach visits are non-billable. So for our outcomes, I said before that we had a lot of interest. So to date, we've actually now had almost 1,000 individuals sign up on a waiting list to join our program from New York City. And they're still coming. And we have internally, since we set up our e-consult system, nearly 500 referrals from our own hospital system. And we've treated about 400 patients, including the fact that we had to take almost a year off with the pandemic. We had an external program evaluation from an NYU team that looked at health behaviors and clinical outcomes. And what they found is that our patients are making significant improvements in their health behaviors, including big improvements in their diet quality, moving towards a more plant-based diet, increased physical activity, and better sleep health. And not surprisingly, we've seen very promising early clinical outcomes, including weight loss in our patients, in those who are obese or overweight, improvements in blood pressure, and improvements in blood sugar control in people with type 2 diabetes, and great patient satisfaction, which we love to see. So 2 months ago, Rachel Atchison mentioned that 2 months ago we had a great announcement of partnership with support from the mayor's office and health and hospitals in expanding the Bellevue model to 6 new sites covering all 5 boroughs of New York City. So these are our new sites. We have the original program at Bellevue. We go up to the Bronx. We have Lincoln and Jacoby that are going to have programs. In Queens, we have Elmhurst. In Brooklyn, we have Woodhull and Kings County right across the street. And then in Staten Island, we're going to have the Gotham Vanderbilt clinic site. So we're extremely excited about that. So all of the new sites are going to be based on the original Bellevue program model, but with some key upgrades. So first of all, we realized that we really needed a partnership with behavioral health. So we were seeing so many patients that were experiencing depression, anxiety, disordered eating, and things that patients I think would really benefit from therapy or other kinds of treatment for these conditions that we were not necessarily able to offer. So we're going to have a wonderful collaboration with our licensed clinical social workers and psychiatry team. Number 2, community health workers. We are so excited about this. So our community health workers, Bellevue and Health and Hospitals already has a really robust CHW program, and we're going to have 2 community health workers at every single site. And the CHWs are going to be the bridge between what we're working with patients on in the clinics and in the groups to the patient's home and community. So they'll be able to go shopping with our patients, grocery shopping. They'll be able to help them work out the details around meal prep. They'll be able to say, okay, so how can we get some movement into your day? What's going on in your apartment where we can work out a way for you to get more movement into your life, and really help also address our patients' social needs. Help us continue to screen for food insecurity, help our patients get food when they need it, make referrals around housing and other issues that our patients may be having that make it really hard to make lifestyle changes. We are going to hire nurse practitioners to join our dietitian and health coach team to turn our group classes into shared medical appointments. And that's really for financial sustainability because these are billable visits. And this is how most lifestyle medicine programs are conducting group visits now. And finally, we're going to have produce deliveries for our patients from New York farmers. So we're super excited about all of that. We're also going to train all of the new clinical staff that we hire with a partnership with the American College of Lifestyle Medicine. We're going to have the ability to use their Lifestyle Medicine Board Review course for training all of our new staff, as well as a couple of their online nutrition courses. We're going to create, in partnership with an organization, to create a culinary medicine course for our staff so that they can actually take the nutrition science to the kitchen and have practical approaches with our patients. And finally, everyone will get a lot of hands-on training from our own nutrition and lifestyle medicine team. So what are some of the challenges and opportunities that we have moving forward? Well, first, I think it's, I want to say that I think it's not, we have to think about what it's like to treat a very diverse patient population. So we have people coming from all walks of life, from all cultural backgrounds, different levels of literacy, different levels of health literacy, and we really need to figure out what is the best way to scale a program like this when you're treating patients from such different backgrounds. And so that's one of the things that we're going to continue to explore, as well as the digital divide, because we know that since we're running a lot of our sessions on video, that can be very hard for some patients. We've definitely seen there are individuals who struggle in terms of their computer literacy to be able to attend a session online. And so we really want to figure out how to address that and probably have a hybrid with in-person sessions as well. We want to partner with community-based organizations and faith-based organizations to reach more communities in need. We want to strengthen our capacity to meet our patients' social needs and train more providers in lifestyle medicine, because we really need, there's such a demand by the public, we really need to get more people trained. And finally, we would really like to advocate for more payer coverage of lifestyle medicine services, especially our dietitian visits. And I encourage everyone here to write to your representatives to support the Medical Nutrition Act, which has been before Congress now for a few years. This is an act that would really expand the number of conditions for which Medicare would pay for a dietitian visit, and it's so overdue. So please do support that. So I'll finish with a testimonial from one of our patients who was in our program from the beginning, and he said, since starting the program 4 months ago, I've lost 18 pounds, lowered my blood pressure, lowered my triglycerides, and reduced my blood sugar. The program is nothing short of life-saving. I hope it can continue to be offered to more New Yorkers. So do I, and that's our goal. Thank you.
Now we will hear from Dr. Ostfeld.
Dr. Helsner, thank you so much for that very generous introduction. And SUNY Downstate, thank you for inviting me here today and for this incredible conference. Ms. Atchison, thank you for your incredible work in the mayor's office pushing this forward, and the mayor for his amazing work. Dr. McMacken, thank you for your pioneering, amazing work at Bellevue. And I want to especially thank the medical students sitting in the back here who represent the future of all of this. So thank you for the incredible work that you're doing. It's a real honor to be here today. Let me just figure out how this works. That's not how it works. That's how it works. Okay. These are my disclosures. So, where are we today? How are we doing in regard to health and nutrition? Now, this is a really fascinating study published by Dr. Bundy last year in the Journal of the American Heart Association. And they looked at just that. They estimated the impact of achieving optimal cardiovascular health among US adults on cardiovascular disease events. So what they did is they looked at 7 different lifestyle measures, Life Simple 7, invented by the American Heart Association. It's smoking, body mass index, physical activity, healthy diet, total cholesterol, blood pressure, and hemoglobin A1C. And I want to focus on the healthy diet score for a moment. And in this study, they looked at 5 elements of a healthy diet. And if you had 4 or 5 of those elements, you were considered to have an ideal dietary pattern. If you had 0 or 1, you had a poor dietary pattern. What were those 5 elements? Low sugar sweetened beverages, low sodium, 2 servings of fatty fish a week, 4.5 or more servings of fruits and vegetables every day, 3 servings of whole grains every day. If you had 4 or 5 of those, or 4 or 5, you had an optimal dietary pattern. 0.7% of the US met the criteria for ideal dietary pattern, and approximately 75% met the criteria for poor. We are miles away from where we need to be, and tangentially, and I know you all feel the same way, there are often multiple internecine wars about this diet is extra perfect, that diet is extra perfect. It's a distraction. We are so far away from where we need to be that we have a long way to go before we need to be having those kinds of arguments. So how about overall cardiovascular health? If you had, for all of those, they gave 0, 1, or 2 points. 2 is ideal, 0 is poor, 1 is in the middle. So for high cardiovascular health, which is 12 to 14 points by their measure, 7% of the US. This gets into the lifestyle program that the mayor's office, that Dr. McMacken and her team are pushing forward, and Ms. Atchison is pushing forward, 7%. Low, 59%. Okay, why does it even matter? Why does it matter? Well, in this slide, if you look at the healthy diet score and you look at the bluish line, they estimated that if everyone adopted a healthy diet as they defined it for 1 year, that would lower cardiovascular event rates by about 40%. 1 year. And just look at high blood pressure, which is also obviously incredibly lifestyle linked. If everybody obtained an ideal blood pressure after 1 year, another 40% reduction in cardiovascular event rates. There is a huge opportunity, and SUNY Downstate is helping to lead the way to make it happen. So I'm in the Bronx at Montefiore Health System, and there are about 62 counties in New York State, and the Bronx is 62nd in terms of health. And the last time I checked, they were nowhere near 61. And there are actually campaigns no more 62. And to my understanding, the Bronx is one of the leading least healthful inner cities in the US. And this is where our program is based. And our program has 3 general arms: a clinical arm with an inpatient and an outpatient component. I'm going to dive into the inpatient component in more detail. There's an educational arm, and there's a research arm. In terms of the outpatient arm, which was where the first thing began about 12 or so years ago, patients come to see us in one of 2 buckets. The first is that they're just referred to us for a general cardiology reason, and the patient may not know that we have even a wellness program. And the other bucket is that they come to us specifically for a wellness program. Regardless of how they get there, we work with them in clinic to help them adopt a healthier lifestyle. We go through the usual cardiology stuff, but we weave in nutrition, largely plant-based nutrition, and other lifestyle changes into every visit. We have a very specific handout we give them with checklists, a check, 3 servings of green leafy vegetables a day, 3 servings of other vegetables a day, etc. We try to tap into their why. Why do you want to make a lifestyle change? What is your motivation? And we are dynamic with them, because obviously that changes from time to time. Pre-COVID, so we would also then invite patients to our Saturday morning sessions, which would happen once a month or every other month, about 5 hours, where I'd speak and RD would speak. We would serve a plant-based lunch for patients. We did not charge patients for the visit. We funded it all through donations. We have patients come with a friend or significant other to help them along the way, because it takes a village for real change. But that paused with COVID. But what we are still able to do is our visits in clinic, and I will often see people every 8 to 10 weeks or so for a very quick blood pressure check, and it's really an excuse for accountability. So that is our outpatient arm, and actually this is just a random piece of data from, at one point I just looked at 40 consecutive patients that we saw in the outpatient arm, and you can see that their LDL fell a little over 20 points over an average of about 7 months. That's outside of medication change. We have an educational arm, so we're able to have the opportunity to speak at wonderful conferences like this. For the medical students in the back, I personally have been giving the preventive cardiology introductory lecture to the second-year medical students for the last 9 or so years as part of their core curriculum, and shocker, it's very plant-based. Don't tell anybody. And we've been able to be involved in a variety of educational initiatives, one of them a podcast, which I'll mention at the end. We also have a research arm as well. We've had the chance to publish a variety of clinical statements across multiple medical societies, publish case reports, reviews, and we are about to launch a randomized controlled trial that I will mention more detail a little bit later. A little bit of positive data there. And this is the study that Dr. McMacken was mentioning by Dr. Kara. And my slide is much more complicated. But if you look at the reason I put this study up is because just like with Dr. McMacken and her team, I have patients come to me and they tell me, "Doc, heart disease runs in my family. Diabetes runs in my family. I'm gonna get it." Well, genes matter, but of course, lifestyle matters too. And this study hits right at that. Complicated slide, amazing study. And so what they did is they looked at about 26 different genes that if you have them, you have higher cardiovascular risk. And not surprisingly, in this study, the more of those genes you had, the greater your cardiovascular risk. So why is it interesting? It's interesting because they also put people into tertiles of lifestyle. And so here, if you just focus on this group here, this is the high genetic risk group. This group has the unhealthy lifestyle, this group intermediate, this group the healthy lifestyle. You can see if you go, even if you have a high genetic risk, from an unhealthy lifestyle to the healthy lifestyle, you lower your risk of a future cardiovascular event by about 50%. How did you get into the higher lifestyle group? You had to exercise at least once a week. And you had to eat about 50% of a long list of healthy foods like vegetables, fruits, whole grains. Only 50%. Imagine if you exercise 4 days a week. Imagine if you ate from 90% that. You would think that your risk would fall even more. So another aspect of our program is the inpatient program that I wanted to focus a little bit more on. We were fortunate to be able to publish an article about it, and we really meant it as a how-to. So if someone is interested in creating some kind of inpatient plant-based program, they could use this and adjust it to their specific system. And it's published in the International Journal of Disease Reversal and Prevention. And what used to happen is I would, around the hospital, I'd go see a patient, go in their room, I'd go rah-rah plants, leave. 5 minutes later, dinner was served, and it was chicken. I'm totally undercut. So I'm like, this is no good. So fast forward a lot, and we created plant-based meals for inpatients. We have forks over knives playing on continuous loop on one of the inpatient channels, and we have a handout that you can give to patients. So now, instead of being undercut, I can go into a patient's room, say the same thing, order the plant-based meal, put on forks over knives, which also has Spanish subtitles, and give them one of the handouts. And so now, I have my plant posse with me. So there are 3 key ingredients for our program. And one is, of course, having physician interest, and everyone here has that kind of interest. The other one is righteous indignation. Okay, the 0.7% only of our society that is eating a healthy diet, that's enough for righteous indignation. And you kind of need to be a friendly pit bull with a plan. So this is, so we have a 6-step program. We made 6 steps in our article. Physician, you need to have support from an interdisciplinary team, just like Dr. McMackin's amazing program at Bellevue. So you need a physician lead, someone who's interested in it. You need the director of food services. They understand purchasing, they understand billing, they understand how your system cooks and makes food. You need the director of nutrition. There are certain government mandates that have to be met. There are a variety of different diets that need to happen, puree diets, all kinds of things that they need to be a part of. And if your hospital outsources to a large food company, then of course you need your liaison to that food company to be there with you as well. Step 2. So you have to develop your recipes. And I literally sat down with nutrition, and over a few months we went back and forth. This is good, that was, no, I don't like this, I like that. And suddenly we have a week's worth of a menu. And then you have a multidisciplinary meeting to refine the recipes with food services, a whole bunch of stakeholders. You want lots of people to have a skin in the game, to feel an attachment to it. And we refined it. At one point we had a little hummus thing, but then the biller said, we don't have the resources for that. Okay, no more hummus thing. And so you keep adjusting it to fit into your system. And then we refined the recipes, and we had chefs from multiple hospitals in our system weigh in so that it was sure to be ethnically and culturally appropriate and hopefully tasty. And working with your EMR, your electronic medical record system, simultaneously is really helpful. You want to have the diet in a place that's super easy to see, and you have to come up with a name. And those things sound simple. They take a lot longer to accomplish than you might think. So starting on that early is important. Because ours used to be, you click on diet, and you have to click restricted, and you click vegetarian, vegan, and then you find cardiac plant-based. So it's kind of hard. You want to get rid of all the friction points. Step 3, patient education. So hopefully we're doing this even briefly. Everyone's tight on time, but discussing with patients regarding the importance of their healthier diet for their care, even for a moment on rounds. We have the handout. We're actually refining it now, but we'll have the handout to give patients, and you could turn on the documentary film, Forks Over Knives, to help outsource some of that education. There are multiple other wonderful documentaries that really help reinforce things for us that I lean on much more now that I no longer have those Saturday morning sessions. And quite frankly, I've been leaning on the game changers quite a bit. But this gets to the theme of we do not want perfection to be the enemy of good. Celebrate the victories, even the smaller ones. In this wonderful study by Dr. Song with about 130,000 people with 3.5 million person years of follow-up, they asked, if you replace just 3% of your calories from animal-based protein with 3% of calories from plant-based protein, is that good? Is it not good? Turns out it's good, just 3%. That change, 3%, is associated with living longer. And they had so much data here that they could look at different types of animal foods. Processed red meat, if you replace 3% of that with plant-based protein, that's a 34% lower hazard of death. Unprocessed red meat, 12, poultry in this data set, 6, eggs, 19, fish in this data set, 6%, but all pointing in the same direction. So we do not need to have perfection be the enemy of good. Staff education is critically important. Having staff lectures, small group educational sessions on the diet. Support from the nurse managers. The nurse managers run their floors, and so they can help you get the information out to the team on the floor. If you're about to kick off your program, in particular, having an outside speaker, someone come in, give a big grand rounds that could help kick it off and maybe serve some of the food at that session. One thing that I would love to have happen at Montefiore that I have not been able to get to accomplish is having a required practical video that all associates need to watch. Now, as you know, when you're part of a medical system, you have to credential and re-credential, right? Everybody does it every couple of years. People come, people go. It's like herding cats. When do you have them? When they're credentialing or re-credentialing. So, and look, nobody likes to do it. It's a ton of work. It's basically the starter kit for burnout, but you have to do it. And so what I want to have is like a 6 or 7 minute video. That's all. Half of it is data as to why eating more plants is good. Half of it is practical. This is what the meal looks like. This is where you click on the electronic medical record. This is where the handout is. But I've had the good fortune to work with a large medical system in Appalachia that is moving ahead to doing exactly this thing. And it's a wonderful way to herd cats. And then, of course, having tastings for the staff so they can see it's pretty tasty. Then you want to roll out the program. What I did is I rolled the program out in 3 hospitals simultaneously. Not a good idea. I would recommend piloting the program on 1 hospital floor. Look, our first day we did it, cow's milk came up. You got to plan, do, study, act. You pilot it on the floor, you get the kinks out, and then you could roll it out, I think, more widely. I think that's a more optimal approach. And then, of course, evaluating the program objectively and subjectively. And one very important subjective piece of information that we learned, and it comes as no surprise, when you serve plant-based foods, this is not, at least in the Bronx, and I'm sure for here as well, this is not how people are used to eating. They are not used to eating this way, and the food is foreign to them. So oftentimes they would be turned off to it. So what we did is we found that if the PA or the resident who's ordering the meals just tells the patient, we are ordering you healthy food to help protect your heart. That's it. That has really increased adoption. And we also never say the word vegan. Because you could be junk food vegan, you not be vegan, you could be healthy vegan, and that's there's ethical connotations that some people like and some people don't like, so it's kind of toxic sometimes, so we just don't even use that term. But that little preamble has been very helpful. So, so another idea, and I lost track of time, I think I'm okay. So another idea, keep it simple. And it's borrowing a phrase from Bill Clinton. One thing that I've been doing just recently is we use this term called GDM as in Mary T, GDMT, that would probably be very familiar to the physicians in the audience, guideline-directed medical therapy. That's a brief term that we use for guideline-based therapy for heart failure. There's a whole bunch of medications we use when someone has heart failure, GDMT. And that gives it the imprimatur of guidelines because it has guideline-based support. But you know what? So does nutrition. The American College of Cardiology guidelines recommends largely a plant-based diet, as many of you here know. So, all right, so what? So I've started to play with the term GDN as in Nancy T, guideline-directed nutritional therapy. Now you have to write it out because nobody knows what that is. But I'm like, why not do that? We have the same imprimatur, the same evidence base that these other medications have, so why not give it that gravitas? We also, we have a whole bunch. I think we have one of the biggest cardiology fellowship programs in the country, and what I do is I have our cardiology fellows put this note in their a consult note for inpatients. Does the patient consume at least 5 servings of fruits and vegetables daily? Yes, no, deferred. And so the reason, and we have it right over the assessment and plan because the real estate matters. People don't often read the middle of the note. They'll read the beginning and the end. And it's there, so the patient knows it's important, the fellow knows it's important, anyone who reads the note knows the cardiology thinks it's important, and then fast forward a few years, people graduate. They go all over the world, and hopefully they'll take some of this with them. So 3 key ingredients, a 6-step plan, and keep it simple. I'm running low on time, so I'm gonna skip this for now, but I wanted to talk about 2 other things. I wanted to talk about erectile dysfunction briefly. It's something that we've been focusing on more in our clinic. There is clear randomized controlled data that a Mediterranean-style diet, exercise, and weight loss can improve erectile function. We call erectile dysfunction the canary in the coal mine for heart disease because usually it presents a few years before. Why do I wish to focus on it? Because it may be uniquely motivating for people to help them adopt a healthier diet, a healthier lifestyle. It's very common. You can see the numbers right up here, and I suspect it's more common than that because people just don't like to talk about it. And we are very fortunate that we are going to be launching, hopefully soon, a randomized controlled trial looking at the impact of dietary pattern on erectile function in young, healthy men. I don't know what it's going to show, but our hypothesis is that a plant-based diet will improve even normal erectile function. So hopefully there'll be a lot of things that we can do with that information, but we'll see what it shows. And along the lines of education, I did want to mention our podcast, and this is something that all of you could do with the connections that you all have. But one thing we were able to do is we worked with the American College of Cardiology and created a cardio nutrition podcast, which is about 15 episodes focused on cardiology and nutrition, on guidelines, on different dietary patterns, on billing, et cetera, to try to get it out to a wider cardiology audience. So thank you very much.
Dr. McMacken, if you could come back up. We have a few minutes to take some questions from the audience, if you have some for these wonderful clinicians. Thank you so much. And Rachel, yes.
Hello, I enjoyed your presentations very much this afternoon. A lot to learn, a lot of good statistics to pass on to my PT students. We're doing back here, we're looking at the Zoom link and seeing if there's any questions that comes in. One of the questions that came in, there's a lot of nurses or nursing students watching this on Zoom, and Dr. McMacken, when you were talking, some of them said, what about nurses? What about nurses? And then, of course, you answered the question even before the end of your talk, because you said with the new program across the 5 boroughs, you would be implementing nurses. I want to put in a plug for physical therapy as well, because I see you have exercise trainers, but at a place like Bellevue, as an example, they have a whole staff of physical therapists. You could have them rotating through your clinic. I'm sure some of them would be glad to do that. So I'm just putting that out there.
I personally would love to have, there are so many different disciplines that we could include, and physical therapy is a great example. So I thank you for raising that, and I know actually the American College of Lifestyle Medicine has a whole track for physical therapists and an interest group for physical therapists, so they're a really integral part of lifestyle medicine, and perhaps in our phase 2 expansion.
Sure.
And I just want to add that every single person in this room has a role to play in building this movement. Obviously, I think a lot of us here are incredibly passionate about this field, but there are a host of other folks who would benefit from knowing more about this field, and that includes anyone in PT, that includes in a lot of different disciplines. And then just reminding, if you do not know one of the other plant-based advocates in the PT, Karan Dada, definitely should. So we'll make that happen.
Hi all, this question is more so on the data and research side of things. Is there a way you all are quantifying dietary compliance for these patients to further the evidence that you don't have to be 100% in this plant-based lifestyle to see results?
Well, so we are under-resourced in that. That's a great question. It will be wonderful to have that. The way that I'm able to track it, which is exquisitely crude, is I will ask patients what percentage do they think their diet is plant-based or to the degree that we had discussed. And that's what I'm able to track anecdotally. If they are 50%, if they say 50% or more, I start to see clinical changes. And for our research study, where we're going to be giving them the food, they're going to be sending us pictures of what they eat. I mean, 3 in the morning, if they're home, they could have whatever, and we're not going to know. But that's what we're going to try to do. Or that's what we're going to do.
Thank you.
Hey, question. My name's Sam. I am a dietitian here at Downstate and also a mindfulness instructor for the doctors, med students, and food service staff. On the patient side, a challenge I have is, giving these recommendations for a plant-forward diet and then patients not being able to access those foods. Our closest grocery store to here is Key Food, a very sad produce section. People are busy, they're working multiple jobs, and so if they need to get a prepared meal, their options are also very limited. And so, Rachel, that's maybe more of a question for you with food policy, but how do we actually make these foods accessible to the community?
Yeah, it is a larger question that we, with the Department of Health and their Shop Healthy team, are kind of thinking really actively about. It's something that, the mayor also wants to show that you can eat healthy from a bodega. You can eat healthy getting the frozen food that's at the Key Foods. Sometimes we ourselves kind of perpetuate that myth of, a sad produce section equals an inaccessibility barrier. And I do want to put a pause in that sort of mentality because I think it perpetuates us not being able to say, eat more plants. Here's the small ways that you can incorporate more plants into your diet as a whole. But it is a larger question that we have just begun to scratch the surface of, and you will be seeing the administration dedicate our time to a lot more throughout the next few years.
I mean, it's wonderful that we have Ms. Atchison here with us. And yeah, I totally agree with you. That is a larger societal question. And there's unfortunately data that even if you say there's a food desert, if you will, and you put a supermarket there, you have a nice produce section, or have the healthier access to the healthier foods, it doesn't mean it's going to get eaten. That's unfortunately been proven time and time again. So we are really going to have to work on ways to make the healthy choice, the easy choice, and the desirable choice.
Thank you.
So first, let me thank all of you for coming and for your contributions. Dr. Osfeld has created, they've all created sort of silos of sanity and plant-based excellence and enthusiasm. Dr. Osfeld in the Montefiore system, McMactin through Health and Hospitals, and the fearless Rachel is taking on the entire city of New York, God bless. And the question I have for you is, the more I get involved in this field and work with ACLM and others, the level of ignorance might be a kind word, but a lack of understanding of plant-based medicine, particularly by physicians, is very apparent. Even within primary care, whether it's PrevMed or Family Med or internal medicine, there's a lot of folks who don't have any idea what this is. And then you get into the specialty levels, and there was a billboard in Brooklyn that said, "Forget about it." They just don't know. So I'm interested in your experiences at the institutional level, the health and hospitals level, the city level. What do you encounter? Do people embrace what you do and doctors come up and say, "Great"? Or do they look at you and say, "What the heck are you doing, and why should I even care?" And how do you deal with this this attitude that just seems so unfortunately prevalent now?
From my perspective, it's all of the above. We see all of the above. There's some people that resonate to it right away, as you know, and there's some people that'll give you the Heisman for years. And it is a very large issue. There are people who are working to get nutrition-related board questions on various medical exams, which will make a difference in terms of what medical students focus on. We've been at this for a while now, and even in my 9 or so years giving the medical students a lecture about largely plant-based nutrition, they know, even now compared to 8, 9 years ago, they know a heck of a lot more about it. We are benefiting from a societal level wave. There's a wonderful study by DeVries that shows that about 90% of cardiologists say that they know that nutrition therapy is helpful, but about like 2% of them feel comfortable giving nutrition therapy. So there is an educational gap which could be filled by various CME events just like yours. So I think what outside of some sort of mandate of 10 hours of CME nutrition education a year, it's silos, just like you're saying, silos of change that hopefully have leaks and lift up other people as we go. You talk to your colleague in the hallway, this person talks to that person, we talk to the medical students, and next thing you know, half a generation later, things have really changed.
Yeah, I would definitely agree with that. I think our experience, specifically at Bellevue, has been colored by the fact that Dr. Sapna Shah, who was on the panel earlier, and I really launched. We had a fellowship. We had the opportunity to do a fellowship in nutrition and develop a curriculum for our faculty colleagues at NYU on nutrition. And so we started out with that. We started by teaching the faculty about nutrition, and it was, of course, a largely plant-based approach. And from there, we moved on to start teaching the residents and start teaching the medical students. And then we started moving on to teaching the staff in the clinic, the nurses, the diabetes educators, our medical techs. And so we had staff engagement events, we had plant-based potlucks, and so everybody got really engaged. And then when our residents see patients in primary care clinic and they go to precept with an attending for the case, most of us are on the same page and understand the value of nutrition and take it, understand it for what it is. And I think sharing the more that our residents have an opportunity to use and leverage nutrition and lifestyle in their practice, they'll start seeing changes in their patients, and that will convince them. The science will intrigue them, but seeing it in their patients will convince them. I taught an intern last year on it was her first day in clinic, and she had a patient who had a new diagnosis of type 2 diabetes. And you better believe we talked about nutrition that day together. And she went back to the room, talked to her patient about a plant-based diet and exercise, and now that patient went into remission. Their diabetes went into remission, and a year later, she's still talking about it. She's like, I can't not talk about it when I see patients with diabetes now. I'm like, that's the point.
I have several things to say about this. We can talk more after for anyone who is interested in further thoughts, but a quick synopsis is I largely think that it's inertia. We have been conditioned to think that the medical healthcare system is one that is really a sick care system, one of prescribing, not of looking at the upstream, reasons. We have a financial system built around that. We also have a communication strategy problem. I think Rob was exactly on point around we don't have the luxury of having to talk about the ideal diet. I think the message that all of us have is eat more plants, and I think that getting that across in a unified comms way is one that we have struggled for a decade. It's not as if the science has radically changed in a decade, but that communication strategy has not progressed as fast as some of the programs. I mean, the fact that we're going from pilot to policy, from 1 clinic to 7 in the city is huge, but it doesn't, it's a drop in the bucket for what we need. And so actually this coming week, I appreciate the accolades, but Nate Sherfinsky actually is behind a lot of what I do. And so Nate is helping the Deputy Mayor for Health and Human Services convene a lot of hospital executives across the city. And Dr. McMacken will be presenting at that to get more of the non-H&H folks on board. I wish there was more examples like Rob with Montefiore, but sadly, there's only a few right now. Excited for getting more, so that's just a little bit.
Hi, my name is Mare. I am a health coach and also an organizer for the Latin community in Plant Power, Metro New York. I actually have 2 questions for all of you. The first one is, how do you see the role of health coaches in this movement, and if you see a role in it? And the second one is, I see the BMI in multiple studies, but also some people might show to have an overweight or obesity on your BMI, but they might just be, have a lot of muscle. Do you consider this to still be a good measurement of health on the studies?
So great questions. So regarding the health coach, well, I'm a huge fan. I know Chrisanne is our health coach in our program and has done an amazing job at really galvanizing change in our patients. And I think there is a role for health coaches and health systems around helping patients' action plan around the nutrition prescriptions from dietitians and the lifestyle medicine plan from physicians, and really doing that concrete work of helping patients understand how they can move forward with those action plans and guiding them. So I'd love to see more of that. Regarding your BMI question, I think that's, I'm 100% on board with you. I don't think that we can really necessarily judge a person's health by their BMI at all. I think there are definitely people who have what would be considered an elevated BMI who are in better health than someone who has quote unquote a normal BMI. And so there's many factors that go into health. I think one of the things that we have decided as a team on our program we want to be very conscientious about is if a person comes to us, who is in what would be considered an obese BMI category, if they feel fine and they don't feel like they have any health concerns and they don't, then that's okay. That's where they are. We know that independently, as BMIs go higher with obesity, there are definitely health risks, but that doesn't necessarily mean that by looking at someone you can determine what their health status is.
Thank you.
Yeah, I mean, behavior change is the holy grail. We all kind of know that eating kale is good for us, but to get ourselves to do it doesn't always work. So health coaches can be wonderful at helping us make these kinds of changes. And yeah, I mean, BMI is a great research tool. It's not as great for an individual person. So epidemiologically it can be helpful, but of course, the person sitting across from you could be Arnold Schwarzenegger, BMI 35, or someone who hasn't exercised since 1970, BMI of 35. So it's clearly not as precise for an individual person.
And then I just want to take a quick second to say what an integral role a grassroots organization like Plant Powered Metro New York has played in the ecosystem of New York City and plant-based nutrition. So one, thank you for your individual service, but two, thank you to everyone here who has spent time in progressing Plant Powered Metro New York's movement and vision, because you all have been a force to be reckoned with. So thank you for that.
Thank you.
I have a comment and a question from the Zoom chat. The first comment is to please be sure to include dentists in your team as well. People see dentists perhaps more than they see physicians. They have to go at least twice a year for their teeth cleaning, right?
There is room for everyone at the table.
I know. But this is just a comment from the chat.
I think the New York Knicks are joining Bellevue's team. I'm not sure.
Of course. And then there's a a question. Do you have any suggestions for maintaining currency in lifestyle medicine once the conference ends?
Maintaining what, I'm sorry?
Currency? I don't know who
Currency?
they were addressing. So
I think we all have a passion for lifestyle medicine after 5 p.m. today, so I think we'll just continue on.
And it's funny with the dental health, I guess it's not funny, there's clearly a link between periodontal disease and a variety of other diseases, diabetes, poor obstetrical outcomes, suboptimal cardiovascular outcomes. There's a randomized controlled trial in the New England Journal of Medicine, I believe in April of 2006 or 7, where they took people with periodontal disease and randomized them to usual care or very intensive periodontal health care. And the intensive arm had improved endothelial function after 6 months, and that was their endpoint. And so actually, I have on my little checklist that I give patients flossing once a day.
Just for the currency question, I'll put on my ACLM hat here, but the American College of Lifestyle Medicine would welcome you as a member. It's not very expensive, and they have incredible free resources, ongoing educational opportunities. They have what are called MIGS, member interest groups, where you can get involved with like-minded individuals, whether it's by a specialty or a special interest, and have discussions. They have meetings, they have chat rooms, they have blogs. So look into ACLM if you want to stay, current.
And if you have not heard about their conference, the Conference on Lifestyle Medicine, it is a phenomenal conference that sadly for the past 2 years they've had to cancel for the in-person version. But I think this year they'll probably
It will be in the
resume.
fall in person.
So
yes.
I'm very excited, very excited.
Yeah. And one word on BMI. We talked about the high BMI, but the converse is that not everybody with a low BMI is healthy. There's something called TOFIs, right? TOFIs. Thin on the outside, fat on the inside. These are folks who are very thin, have a low BMI, but they have awful diets, they eat all the wrong foods, and inside their arteries are clogging and they're on a path to disaster. So BMI is a very rough guide.
Hi, good evening. My name is Shanice. I'm a night nurse, to be specific. I noticed that a lot of people are asking different questions, and in reference to the programs that you're doing now and expanding to the other HHC hospitals, I'm presently at Kings County ER at nights. We know that those of us who work nights, we tend to not get any information at all. In fact, I got this information from my sister who works upstairs in the research department. She sent it to me, and then I saw Rachel's information and I texted her. But how can you make that information available throughout the HHC systems for us? Because you could see the difference in our weight for day shift versus night shift, and we are the ones who are eating late and doing those unhealthy practices, even for me who is plant-based. So how can you get that information available for those at nights that we could get our community and our patients aware of the program that you have?
I love that question. So first of all, all of our programs are open to anyone in the community who meets our criteria, as well as any employees in our system or patients in our system. As far as getting the word out, I talked today about the expansion of these dedicated lifestyle medicine programs, but that's actually only part of my work in my role at Health and Hospitals, the nutrition and lifestyle medicine. And the other part is to meet the needs broadly of our patient community, for the whole Health and Hospitals community and our staff around health, nutrition and lifestyle specifically. So a great example, I'll bring up Lily Correa, our dietitian for our Bellevue program, who's now working with me as well. She helped put together for National Nutrition Month a series of webinars that were viewed by over 1,600 staff throughout all of Health and Hospitals, including discussions around plant-based nutrition in general, fiber, protein, and a cooking demonstration. So it's nutrition focused, but we're planning more events like that to really, and they're recorded and anyone can watch them, so you don't have to watch live. We have many other exciting things up our sleeves to help engage our staff in getting excited about eating healthier and finding out what they can do to support each other as peers in that, as well as other lifestyle changes.
Thank you. Thank you. Well, this has been a really wonderful day. I really appreciate the fact that you've all been here for this, and I hope that you take some of these messages back with you. I just want to make a comment about CME. So you can expect an email from our CME office that will have a link to the program evaluation for this conference. I would really appreciate your feedback on your experience here today. And if you signed up for CME, there will also be information on how to get that. So please keep an eye out in your email. And with that, I'm going to pass it over to Dr. Rosenfeld for some final remarks. Thank you.
Final remarks. Well, the first one is we are remarkably on time, right? 4:15, it's 4:15. So that's always good. But first, a couple of thank yous. Again, thank you to Beth Helsner. I mean, this was a labor of love, and I'm sure she's going to sleep well this weekend, knowing that it's behind us. Beth, the whole planning team, all of our volunteers, the students, everybody who helped out, really an incredible job, and even our own Cafe 101 who did the catering. That was one hefty vegetable sandwich, I will say. I think it weighed about 5 pounds. And the hummus was also good, so I hope you enjoyed the plant-based food. And the fact that you're all still here says something. We didn't have much attrition. I don't know what's happening on Zoom, but hopefully they're still with us too. So, to sum up, part of this, and it was alluded to by Bob Osfeld and some others, it's not just about telling people what to do, it's about getting them to do it. And a big part of lifestyle medicine has to do with promoting behavior change, which is the role of coaches, but also, if you get into the field, you learn a lot about positive psychology, about motivational interviewing, about cognitive behavioral therapy, assessing readiness to change, trans-theoretical models, all sorts of stuff. It's very interesting, but in learning about lifestyle medicine, probably the most meaningful thing I learned is the definition of a positive mental attitude. I love this definition. It's very simple. It's 3 things, okay? And it's easy to remember. All right, contentment with the past, happiness in the present, and hope for the future. 3 simple things. You let the past rest, you be happy today, and you hope for tomorrow. Very simple. So what's the outlook for lifestyle medicine and healthy eating in the future? I think it's fabulous. The enthusiasm at this conference is one example of our presenters, of the people involved. I've become very involved at a more national level with the Board of Lifestyle Medicine, the college, and having been involved in medicine for more than 30 years in various leadership roles, I gotta say, I've never seen a group of energized folks like when you go to these meetings. I mean, it's incredible, the passion. They love what they're doing. And, I go to ENT meetings, and it's all these ENT folks. They're very stodgy, and, it's boring. But you go to these lifestyle things, and it's all these different folks, You've got the primary care, the specialists, the coaches, the nutritionists, the exercise folks, everybody. I mean, it's such a diverse field. It literally transcends every aspect of medicine and specialty. So what's the future? I think we're at a tipping point. This stuff is taken off. That, good to great flywheel, where you got to push the flywheel to get it going. That thing is just starting to really get going. So you're the future. Our students are the future, the residents, and I think we're going to see more and more in residency training, in medical schools, and just in general, this message getting out there. So it really is exciting. I could envision in residency training the so-called core requirements all having lifestyle medicine in there. And actually right now, the American Board of Lifestyle Medicine is working with family medicine to develop something called AIRE, which is Advanced Innovation in Residency Education. It's what the ACGME Family Med is looking to extend their training from 3 to 4 years, and to include this option to specialize in lifestyle medicine. The preventive medicine folks, we're working with them in developing something called a focused practice designation, which is with the ABMS, the medical specialties, where you can get a special emphasis in your training in lifestyle medicine. So there's a lot of cool things going on. But it's late, so we want you to go. Please be kind on your evaluations. That means at least fill them out, because we would like to do this in the future. And again, it's you that made this possible, so thank you for coming. And thank you to all our supporters. I didn't say this before, but the medical staff here has been very generous with their support, not just of this, but with the Student Garden and other initiatives. Dr. Riley's office has been very supportive. The city, the mayor's office has been very helpful to us, and others have supported it as well. So, all right, thank you, and have a good plant-based evening in life. Bye-bye.